So over
Yes.
to Dr. Sunil for the quick introduction of the chairpersons of the cornea session, because we are going to take the master class of the cornea after this.
Okay, ma'am. So after the excellent session on the chemical injury,
Very
now
nice.
I will introduce the chairperson of the master class of the cornea. So first Dr. Sunil Kumar, myself, then Dr. Bharti Sharma, she is the HOD of ophthalmology at TMH Hospital, Jamshedpur. Dr. Seema Kumari, she is Associate Professor, MGM Medical College, Jamshedpur. Dr. Nidhi Kashyap, Senior Consultant, Cornea Services at Kashyap Memorial Eye Hospital, Ranchi. Dr. Pooja Kumari, again from the TMH Jamshedpur. Dr. Vishal Kumar, Consultant, Kashyap Memorial Hospital. Dr. Nitish Bhardwaj, Cornea Consultant at Sardha Hospital, Jamshedpur. Dr. Mohit Biskarma, Senior Resident at TMH Hospital, Jamshedpur. Dr. Seema Singh, Senior Resident at Rio Rims Ranchi. Dr. Dipankar, Senior Resident Rio Rims Ranchi. And Dr. Smriti Chaudhary, again Senior Resident from Rio Rims Ranchi. So I welcome all the chairperson for this master class on the cornea session. So thank you.
And I hope all the senior residents, they have joined. So we have called each one of them. So now
Okay.
over to Dr. Niveditha Narayanan. Dr. Niveditha, can you please share your slide?
Yes, ma'am. You are able to see my slides?
Yes, you are audible
Yes,
and
yes.
visible both.
My slides are visible?
Yes, yes, madam.
Okay.
Yes, visible.
Okay. Okay. So I'm just going to talk about pearls in therapeutic penetrating keratoplasty. I'm Dr. Niveditha from Jharkhand Nethralaya. And this is a very basic thing for any postgraduate when they enter into the subject of cornea. So the primary goal here is to eradicate the infection, preserve the globe integrity. It is only secondary that we look at the graft clarity and the visual outcome. We have some preoperative important things that we look at. One, first and foremost, is infection control. To achieve this, we have to look at the causative organism and go for maximum targeted antimicrobial medication. If in spite of all this, the infection is progressive, then we look for an appropriate surgical timing. If the cornea melts in the due course, if there is an impending or frank perforation, it is again an indication for surgery. When we plan for surgery, look at the involvement of limbus, sclera, anterior chamber. In anterior chamber, we have hypopyon. We should know that hypopyon in a bacterial infection is only inflammatory, whereas in fungal infection, it is infective. So that should be taken into account. Lens involvement. If it is an injury-incited infection, we have to look at the integrity of the capsule because accordingly we'll have to plan the surgery. Whenever the posterior segment is not visible, ultrasound biomicroscopy is important to look at the status of the posterior segment. In our setup, we have the liberty of retinal colleagues who will join us when we venture into the therapeutic grafting. Now, once all of these is done, procuring donor cornea, we need not wait for an optical grade of the cornea. Even a therapeutic grade is good enough because if you remember the goal, it is eradication of infection and integrity. So the faster we do, the better it is. In case of larger graft, it is important to look at the donor corneal rim, whether it has sufficient scleral proportion. Now, coming to the intraoperative pearls. Triphoning. Before we go into triphoning, we need to stabilize the globe because these eyes are often very different and you are in for many surprises. So Fleringa should be used in all the therapeutic grafts. Next is the most important thing is the sizing. Sizing of the host triphonation. There should be a healthy 0.5 to 1 millimeter of clear margin beyond the infected area of the cornea. And then when we plan for the donor cornea, you'll have to be oversizing the graft like usually 0.5. If it is a collapsed globe or a soft eye or a perforated cornea, you can even oversize it by 1 millimeter. At the stage of open sky, it is important to inspect, excise all the necrotic tissue, inflammatory membrane, clear the hypopion, and all material possible should be sent for micro and histopathological investigation. Touching the lens is avoided as much as possible while removing the synecholysis. Vitrectomy also should be done only when it is indicated. Now look at this case. This has a clear lens, limbus to limbus involved cornea. I have done a large corneoscleral graft. I have not touched the lens. The patient post-operatively with reasonable clear graft is still seeing well. It's a young patient, so you don't want to touch the lens. Now, when the patient is coming for later with an cataractus, you can go for an optical graft with lens management, but definitely not when the eye is infected and inflamed. Why? Because you want to avoid positive pressure-induced PC ruptures, which is very common in the open sky stage and leading to vitrectomy. So an anterior segment infection will be easily spread into the posterior segment, which as a surgeon we should avoid. Next is the suturing. We should use only interrupted sutures with tenonylon. The tightening should be just watertight, not very tight, because very often these eyes can be very soft and you don't want to, inflamed tissue should not be crumpled with your very tight sutures. One important thing is definitely do 2 PIs. One, in case one is blocked, at least the second PI will start functioning, because inflamed eye often form heme and fibrin which can clog them, and knot should be buried in the donor side. Post-operatively, all patients should continue the respective antimicrobial treatment. Once the microbiological histopathological reports come, the treatment can be tailor-fit. If the patient is improving, then you can wean off the medication. Usage of steroid. It should be avoided in the active infection state and when the graft has epithelial defect. Now look at this graft. It's a total epithelial defect. No steroid at this stage, even if you have used a good optical grade eye, because we don't want recurrence of infection and graft melt. Now, in fungal infection, it is definitely contraindicated unless we are sure that the infection is completely mitigated. And then when we start using steroid, you have to be very careful. This is a small tabular column which tells when to use what. Systemic antimicrobials, definitely post-op up to 2 weeks. In case of fungal, it is longer. In case of viral, it is much longer. Topical antimicrobials, until the epithelial healing, it should be in maximum dose. And then until the infection is eradicated, definitely some kind of antimicrobial should go on. In acanthamoeba case, it has to continue for months, because we all know that acanthamoeba forms cysts. The cysts are not amenable to medication, and over a period of time when the cyst ruptures, if you're not on topical medication, you are going to have a recurrence. In viral, topicals are not so important. Until the epithelial lesions are healed, you can continue the topicals. Afterwards, it's mainly systemic. Topical steroids, epithelial defect is healed, then under antibacterial cover, in bacterial cases, you can use steroids. It should be withheld in fungal, as I told you. In viral, no role of that when the epithelial lesions are present. In acanthamoeba, for severe uveitis, you need to start a topical steroid. Systemic steroids are reserved for severe cases in general, and in acanthamoeba when there is a scleral involvement. Cycloplegics for ciliary spasm and preventing synechiae due to posterior anterior uveitis is as usual. Tear substitutes facilitate healing, so it should be used immediately post-operatively. Anti-glaucoma medication as and when required. It is important to look at the pressure post-surgery. Avoid pilocarpine and prostaglandins. So when you look at the monitoring of the patient, you will have to look at the graft-host junction and the recurrence of hypopion. These are the 2 early signs where the recurrence will be. Complications, we have already told you how it is. So looking at the theoretical part is one. Now let us look at the case. This is a young child with a fungal keratitis, injury-related infection, and the eye was little soft. Chamber was not so fully formed. So along with antimicrobials, I gave cyanoacrylate glue with bandage contact lenses. Patient was started on dual antifungals and systemic. Did not improve. So we had to do a therapeutic PK. Post-operatively, though there was no recurrence of infection, because of the long duration of closed chamber, patient developed synechia and pressure was spiked. So we had to do a tube AGV. In children, it is very difficult to release the synechia, it reforms, and so this patient had to have an AGV. Now let us look at a second case. This is an acanthamoeba keratitis patient who came with very good vision and only a ring infiltrate. But you can see that it is long duration because the limbus to the ring area is not very clear. So we explained to the patient that it is a severe case. You need a large graft. She was not willing and the lens was also clear. She was lost. She came back 3 months later like this with a total white cataract and vision is dropped. So she has come back and her infiltrate has also worsened. So now she understands it has to be continued. Along with the medication, she was willing for surgery. I did only a large therapeutic graft. I did not touch the lens, though it is a total cataract. Once the infection was completely gone, around 6 months she was on medication. Once everything was complete, she underwent optical PK with ECC IOL. Her vision recovered. But because of the long duration and the severity of the infection, her epithelial healing was bad. She eventually developed PED and the graft was failing. I did an AMT and the eye became quiet, waited for some time, and then she underwent a second optical PK. This is the third PK in her. And with this, I also put an AMT, which is kicking well till now, and she's having a reasonable vision. So though we have a standard protocol, each patient teaches how to titrate the medication, how to change. As the patient's flow changes, we'll have to intervene or withhold the treatment. So in conclusion, large trephination for the infiltrate to encompass a clear zone beyond the infiltrate is important. Excise all the infected tissue with clear margins. Donor graft usually should be oversized by at least 0.5 up to 1 millimeter. Send the material for microbiological and histopathological investigation. Continue post-operative antimicrobial treatment until the infection is mitigated. Use of steroids should be cautious, and in fungal cases, definitely you have to withhold for some time. So the goal is save the eye first, vision later. My references, thank you.
Very nice paper. I must appreciate that you have covered almost everything. I wonder, what do you do? You know, in Jharkhand and this area, we have very less amount of cornea that is available. So, what is your experience about the glycerin preserved cornea for the therapeutic keratoplasty?
Fortunately for us, we have good supply of cornea. We have also got a tie-up with the SightLife. But during the COVID time, we did face the dearth of corneal tissues. At that time, we used glycerol preserved cornea. It does do a good therapeutic effect, but then it will not give you the optical grade corneas. And one important thing when I started using, what I understood is these glycerol preserved cornea for some reason are very easy to have decimate separations. So I even have a publication where I spoke about reverse suturing. Like we go 90% depth. In these cases, I took a reverse suturing anchoring the decimates. So once in the early COVID periods, when we had more and more grafts with decimate separation, we took the reverse suturing so as to retain the decimates. So that is one lesson which we learned. But glycerol preserved eye is a doable project in case of dearth of donor corneas.
Yeah, very nice. My input would be, if you're using a glycerin preserved cornea, because we don't have so much of cornea, optical type. So what we do is preserve them. We use it even after 6 months or 7 months also. We take out the cornea and keep it in the saline for some time. Then the cornea becomes softens, and the transplant cornea, which is preserved, becomes opaque, and it absorbs fluid. So you have to be very, very careful when you're taking the bites.
Correct.
And you very correctly said, to keep the desmoid tumor attached, we can take all the reverse. And it is easier to do a continuous suturing rather than interrupted ones. Of course, when you're doing continuous sutures, you can give interrupted in between also. That helps. A very nice paper, very nice one.
Yeah, thank you.
So now to our next cornea speaker, Dr. Charuta Purani. The topic is every cell counts, the life journey of an endothelial graft from donor cornea to decades of clarity. Over to Dr. Charuta. We have already done your introduction, Dr. Charuta. Dr. Charuta, you are muted. Dr. Charuta, please unmute yourself. Dr. Charuta, you are not audible.
Please call her. Please call him. Please call.
Okay.
Hello, good evening everyone.
Yes.
Is my screen visible?
No, your screen is not visible yet.
Please share your screen.
Yes, ma'am. From here I'm sharing.
Yeah, now it is
Yeah,
visible.
now it has come. Now it has come.
Please put in the slideshow mode. Yeah. Slideshow mode.
Slideshow mode. Please go to the slideshow mode.
So good evening everyone. Today I'm going to talk about a different topic. So apart from the usual surgical steps and the tips, this is the journey of a graft, how it reaches the patient. Ma'am, am I audible?
Yeah, just double click the center. It will be full screen. Just double click. It will be full screen.
Mohit.
Is it okay now?
No. उसी को edit की हो ना. Dr.
You have to put it. Yeah, that's better. Yeah, yeah.
Now it has come. Now it has come.
How?
So today, am I audible and the slides are good?
Yeah, yeah.
Yes, yes. Please go on.
So this is the journey of an endothelial graft, and I'm going to talk very different from what the surgical steps are going to be. So we've been working on this from the last 6 years, and if we think about it, most surgeons would say that the graft survival actually begins maybe at donor selection, tissue preparation, or at the time of surgery. But actually, truly, it begins the moment that the donor passes away. And graft longevity, what we have realized, is a continuum and not a single operation. So if we see that the donor, after that the retrieval, its preservation, preparation are equally important as the next steps of recipient selection, surgery, post-op care, etc. Of course, all these steps are also important. Now we need to understand that the endothelial reserve is a finite amount of reserve, and that because the endothelial cells don't multiply and are stuck in the G0 phase, they don't really regenerate in vivo. And there is a process of progressive loss even when we are living, and which continues when the graft is transplanted. So donor factors that we need to understand include the age, the baseline endothelial reserve of the donor himself, the prior ocular surgeries, how much time was lost between death and preservation, The eye band technique also is very important. The person who is retrieving must have very good technique. The storage, medium quality, transportation, logistics, etc. are also very important. Now, next would come the preparation of the graft itself. So, when do cells disappear? Trephination, peeling of it, the scroll formation, the staining, loading, dyeing, all these injections, all these steps will lead to loss of some of the cells. Now, micro trauma at every step will add before the graft ever enters the eye. And we need to understand that equally important as manipulation is the endothelial actual attrition. So, although older donors will unfold very beautifully and nicely, they already have a very low reserve. And diabetic donors, in addition, we have found even practically, and it has been proved by various studies, that they peel poorly and they peel unpredictably. Now, repeated staining again is not very good for the grafts. Touch points should be minimum when we are manipulating the graft, and the orientation must be maintained as best as possible in the right manner from the beginning. Now, Fuchs endothelial dystrophy, uncomplicated pseudophakic bullous keratopathy are sort of a little bit low risk for a hostile environment. However, pseudophakic bullous keratopathy most often happens in complicated eyes that have had an eventful cataract surgery. Many a times we find vitreous which is present, vitreous tags that are there, or remnant.
Dr. Charuta, I'm sorry for disturbing you. Could
Sir.
you please put this slide in the full screen mode? Yeah, and put it in the full screen mode. Put it in the slide so it will come to full screen mode. Or else this is better than the last time.
Are you seeing the presenter view?
You have not put it in the full slide mode. You have a
Actually, I'm just sharing my whole screen, but I'm not sure what you are seeing.
what we're seeing is the present slide and the slide which is going to come.
Ma'am, you'll have to put it in the slideshow mode. It's downstairs. I mean, in the lower corner.
It is in that mode only. Now, is it fine now? Okay, now select.
Slideshow mode.
The presentation is not yet shared.
Oh, lovely. That's this the one. Yeah.
So now, low risk, yeah. So now, uncomplicated PBKs are generally very rare to find. Most often, the cataract surgery has been eventful, and we see cortical matter, vitreous tags, or lens dislocations, etc. And then we have to correct those. So again, that kind of a hostile environment is not very great. Any previous vitrectomy, previous glaucoma surgery again leads to a rapid endothelial cell loss. And other risks include uveitis or a previous failed graft wherein the inflammation factor is very high. Ocular surface disease also surprisingly does contribute to a prolonged inflammation, and any anterior segment reconstruction or tubes, shunts, etc. will also lead to a hostile environment. So this is a checklist. We need to look at the ocular surface, rule out meibomitis, look at the glaucoma status, whether the IOP is controlled or not, and the iris defects if there is a sector iridectomy that is present. Look at vitreous support, whether there are tags that are present, any synechia that are present that need to be broken. So all these manipulations are preferably done 6 weeks to 3 months before any endothelial keratoplasty, so that the inflammation post these surgeries has come down even a lot. And next thing is the lens status, the pseudophakia, whether it's an appropriate lens. If it's a one-piece lens in the sulcus, then obviously it's going to cause a recurrent release of pigments and going to reduce the graft longevity. Look at the compliance capacity of the patient, the fellow eye, whether it is having a similar outcome. Now, intraoperative enemies are also mechanical. For example, if the size of the incision is very small, or if you have to repeatedly inject, repeatedly unfold, lot of manipulation, contact injuries happening, such as that happens in juniors when we are novices. Fluidics, again, chamber instability, if we've not put the right support, if we've not used fluidics properly, if the AC is collapsing a lot, if the person who is assisting us with the AC control of the AC chamber depth maintenance is not used to our way of operating, unstable AC depth, as I said. And then there is an also, if you have excessive pressure, if you're leaving the bubble for too long, that also adds to the insult. So all these factors are to be taken care of. Now, before insertion, if you have planned every step, you have your backup instruments, especially for iris manipulations or for the graft manipulation. If you've minimized the endothelial contact, your AC is appropriate depth, you've kept the chamber stable, you have an AC flow maintained, your maneuvers are gentle, and you're mindfully doing every step, then the flow is very smooth and the unfurling is also least traumatic. If we underfill, then it's going to lead to a postoperative detachment and rebubbling. And if you overfill, you might get pupillary block and raised IOP spikes, and again that will also lead to a endothelial cell injury. So every second intervention is going to lead to further loss, inflammation, further and earlier failure. Post-operatively, also use the steroids based on the inflammation level of the patient. Don't have a use the same procedure, the same timetable for every patient. Monitor and taper and increase or decrease as per the previous inflammation and also what you expect. Heavily pigmented irides or excessive manipulation, you can prolong the steroids and taper more slowly. Of course, IOP surveillance is also equally important. Educate the patient twice, thrice, 4 times or every visit regarding rejection. Optimize the surface and make sure that the patient understands the need for follow-up discipline. Of course, we know with every rejection we'll use a large number of cells. Every rejection will accelerate the life of the cell, and it's going to eventually the cells are going to die. So glaucoma is one of the most common cause. Chronic attrition, also we know that the graft cells, the cells of the endothelium drop very fast as the graft is implanted in another eye. Add to this, if the preoperatively the patient has had something like a viral keratitis or a reason for repeated inflammations, then also the graft is going to die fast. Now, this is a simple advice that a very good friend of mine gave me, and she said that like in any relationship you have deposits and you have withdrawals. If your withdrawals are going to exceed your deposits, then the relationship is going to fail. And this is these are the factors which healthy donor tissue, proper preservation technique, gentle surgery, controlled inflammation, good IOP control, etc. are going to help in a larger bank deposit. And the more you withdraw, the faster it's going to fail. Now, this is something that we have done in collaboration with the Kammam Eye Bank, and I want to stress on this because this is something new and this is something which is very close to my heart. So we know that a lot of our population is now live longer, they live healthier lives, and a lot of our donors are 80 plus. So can we really truly utilize these tissues, or are they going to end up in somebody's training center or in glycerol? Now, what we have been trying to do is that we know that they are underutilized because older age, obviously the cell counts are low, and then many a times accelerated cell decline happens during the storage, and guttata are also more commonly seen in these age groups. These also lead to rejection of the tissue to be used for optical grade. Now, ROCK inhibitors have shown promise in endothelial cell survival, and we've been trying to maximize elderly cornea viability by using these ROCK inhibitors and other special techniques. So what we've done is all these 80 plus tissues, we've done the biomarker profiling, and we are doing specular and confocal analysis. The experiments are ongoing regarding ROCK inhibitor supplementation, harvesting technique improvisation, and just to see whether the transplant outcomes are improved or not. Now, reconditioning of the epithelium, we know that ROCK inhibitors promote CEC survival in the laboratories, and they prevent, they reverse the contact inhibition which prevents CEC regeneration. Therefore, they have allowed the cells to regenerate. Now, these are the first set of experiments that we did in the bovine cornea, and we injected viscoelastic device at the time of harvesting the corneoscleral rim from the whole globe. And in these we showed that definitely injection of a viscoelastic device led to the formation of less number of dead cell area. So if you can see the first image wherein no injection was used, the area of dead cells is much larger as compared to when viscoelastic device was injected. Now, interestingly, both the HPMC injection and hyaluronic acid injection led to almost similar amounts of endothelial cell loss. And if you can see, the average area staining positive is almost equal in both, and there is no statistically significant difference between these two. So, however, these two groups, that is no injection versus the with injection group, showed a significant difference in the number of dead cells that we found. So, preconditioning with intracameral or viscoelastic devices improves the endothelial clarity, is what we showed in 138 fresh bovine eyes. Now, back to the human cornea, we've done this study is now ongoing, and we have found similar results even in the human cells. All tissues which are not of optical grade above the age of 75 or 80, we have included in the study, and we find that the mechanical buffering and metabolic stabilization leads to better clarity of the graft. And this hyaluronic acid chondroitin sulfate is also having as encouraging results as the inclusion of ROCK inhibitor in the storage technique. So this is the conceptual innovation that we have, that mechanical buffering reduces the stress, maintains structural integrity, metabolic stabilization improves cell viability, and improved optical quality leads to an increased and extended cell survival. So the globe, once we receive a globe, the reduced stress itself, because of the maintained structural integrity, helps us in improving the cell longevity. So recommendations, what we aim to do is that interested eye banks or those who want to now partner with us, we want to replicate this the scale of this in other eye banks as well, and help improve the utilization of these tissues. So we've started a multi-centric study a couple of years ago, and we've recruited 3 eye banks in the same, and hopefully as the graft outcomes come in, we will have more robust data to show regarding the eventual graft survival as well. So of course the laboratory assistance that we have received is also ongoing, and then there will be live dead cell assay data which we have, which is ongoing, and that will be able to give us more data on what we have achieved with this with these modifications. So the other things that we want to include in our research is also AI assisted specular analysis, so that we know that many a times the cells look very healthy, the cornea is functioning very well, but the cell count itself is very poor. And other things include remote telemedicine linked slit lamp photography, and use of all dark tissues for use of all low endothelial cell count for darks, and if we can have dynamic preservation to allow active nutrient delivery to the corneas. So we know now, coming back to the first thing, we are not merely transplanting the corneas, we are custodians of this population of cells, and we need to improve the longevity, because the most common indication apart from infections and dystrophies for a graft is a regraft. So we need to make sure that each graft lasts as long as we can.
It was a very nice presentation. The people who are talking about the penetrating keratoplasty, what I feel that one of the most common cause of failure of the graft is high intraocular pressure, and you get a lot of peripheral antidysphagia. So nobody's talked about the PI. Do you do PI in such cases, especially the PK, and especially when you are working in a relatively inflamed eye, you have to do therapeutic keratoplasty. What is your take about PI?
100%, sir. Every inflamed eye needs at least one peripheral iridectomy surgically. Sometimes in an inflamed eye, wherein say it's a fungal infection or a very fulminant infection, and I'm doing a therapeutic, I do two also, because sometimes the inflammatory membrane blocks one. So,
Yes.
but in routine penetrating keratoplasty, optical ones, where we don't have any nuclear sclerosis, the lens is clear, in those cases I avoid, but I keep a close observation. Or if
So-
it is pseudophakic, then there is no question.
So you mean inflamed eyes you do
100%, yes.
to PBHI in the for therapeutic keratoplasty, but optical you don't do.
Optical, if it is a clear lens, if it is a cataractous lens, then yes. If it is a pseudophakia, then no. Then it's not required.
Good.
Okay. So we have completed the master classes, the preferred practice patterns of cornea and chemical injuries.